Hello everyone, welcome back to MedSound Bites. Today we will be talking about adrenergic receptors. But first of all, I want to take you along and explain you about the different G protein classes, which is our GS, GQ and GI, and how they function. So first we will talk about is going to be GQ, which functions using the enzyme phospholipase C and acts on phosphoinositol diphosphate, breaking it down into diacylglycerol and an inositol triphosphate, which is one of the steps of the glycolysis pathway. Now, this inositol triphosphate is further acting as a second messenger, increases the calcium. Along with that, the DAG is going to act on protein kinase C, and together they are going to cause smooth muscle contraction. If we talk of the GS variant of this G protein class, the GS uses adenylate cyclase enzyme, which breaks down ATP to CAMP, which then acts on protein kinase A and is further going to increase the calcium levels and will be responsible for causing contraction of the cardiac smooth muscles, but it will also be responsible for causing the relaxation of the smooth muscles because it is going to inhibit the myosin light chain kinase, and this myosin light chain kinase is something that is required for contraction of smooth muscle cells. So if it is inhibited, there will be relaxation, and GI variant is the one that is going to inhibit the adenylate cyclase. So it's just going to be the reverse of whatever we learned in GS, which will be cardiac muscle relaxation and smooth muscle contraction. First thing first, we will talk of now about the alpha-1 receptors, which are our GQ variant, which are specifically present within the dilator pupillary muscles of our eye. This is something that is clinically important as well. That is why they are responsible for causing mydriasis, because there will be contraction of these dilator pupillary muscles. They are also going to cause a contraction of the vascular smooth muscles, and thus they will be given whenever there's going to be hypertension, right? And they further increase the intestinal and bladder sphincter muscle contractions along with it. Now, these alpha-1 and alpha-2 variants are basically divided into alpha-1A and alpha-1B. Now, alpha-1A is responsible for causing thus mydriasis, and this will be responsible for causing the constriction of the urethra there along with bladder sphincter muscle contraction. And alpha-1B is for vasoconstriction. It is for vasoconstriction. Very importantly, we should be seeing that if we talk of sympathomimetics, they are going to be our catecholamines like epinephrine, norepinephrine, dopamine, dobutamine, isoprenaline. These are the ones which are used in shock because of this property of these receptors, because they are going to be acting via alpha-1B receptor and they will cause vasoconstriction. So I'll be able to balance out or maintain the BP of a patient who is in shock. Then we move on to alpha-2 receptors. Alpha-2 receptors are the ones, again, alpha-2A and alpha-2B. Alpha-2B is the one which is present both synaptically, again responsible for vasoconstriction, but their main role is that these receptors are also present presynaptically, alpha-2A, which functions by decreasing the sympathetic outflow from the body. Right, they are going to function by decreasing the sympathetic outflow from the body. Right, along with that, they will be decreasing the insulin releases, and they will decrease the lipolysis and decrease the production of the aqueous humor. Right, now since we say that they are going to decrease the sympathetic outflow as a side effect, along with decrease the central nervous system functions, so a side effect of these drugs will be sedation. And alpha-2 agonist, if we talk of, is methyl dopa. This is something that is used in pregnancy-induced hypertension, right? And then there is clonidine. Clonidine is used in hypertensive urgencies. And we are also having some, pre-anesthetic medication, which is going to be our dexmedetomidine. Right, this is something which is used as a pre-anesthetic medication, right, and something to decrease the secretions and sedation. Then we further move on to beta-1 receptors. Now, beta-1 receptors, beta-2 receptors, and beta-3, all of them are GS variant. of the G protein class, and beta 1, we have got one heart, is present specifically in the heart. They will be increasing the heart rate, increasing the contractility of the heart. Along with that, they will increase the renin production. Along with that, they are going to increase the renin production. Then we have beta 2. We have got two lungs, so specifically in the lungs, they are going to cause bronchodilation. Along with that, they cause vasodilation, increases the cellular uptake of potassium, increase aqueous humor production, increase insulin release, and increase lipolysis. Now we said that GS, smooth muscle relaxation. Uterus is made up of smooth muscles. It is going to decrease the uterine tone, and thus can be used as a tocolytic agent like ritodrine, isoxsuprine. These are our tocolytic agents which can be used in preterm contractions. Then we have beta 3. Beta 3 receptors are the ones which will be increasing the lipolysis, and they are known to increase the bladder relaxation. So since they are increasing the bladder relaxation, they are increasing the urine holding capacity of the bladder. So in urinary incontinence, we can use beta 3 agonists. The classic example, mirabegron, bibegron, right? These are the drugs which we use. And since we talked about beta 2 agonists are going to be our bronchodilators, right? Clinically, they are very relevant. We have got short-acting bronchodilators and long-acting bronchodilators. And very classic example of a long-acting bronchodilator being formoterol, salmeterol, and SABA being salbutamol and terbutaline. But a side effect of beta 2 agonists is that they will be responsible for causing tachycardia. If they will be, not selective, they will be causing hypokalemia because they increase the cellular uptake of potassium, and they can also be responsible for causing tremors because we know that beta 2 receptors are also present along the skeletal muscles, and that is why they can be responsible for causing tremors. Since we have already said that beta 2 receptors are going to increase the insulin release, beta 2 blockers are something that we do not give in a diabetic patient because these are the drugs which can mask the hypoglycemic effects in a diabetic patient, and thus beta 2 blockers are a contraindication to diabetic patients. That's all for today. If you find this video helpful, please do like, share, and subscribe to the channel. I will further bring a new video the next Monday. Good luck, everyone, and thank you.